Good afternoon and welcome, sir. Dr. Rajan, sir. Thank you so much for being there at a very short notice. Irshad, now you can start sharing your slides.
Yes, sir. Good evening, sir.
Hi, good evening.
Good evening, sir.
Right.
Yeah, I'll share my.
Where you have to renew your subscription to Microsoft, man.
Okay.
Right.
Can I start the presentation, sir? Hope my screen is visible to everyone.
Fine.
Yeah, yes, sir. So, good evening, sir. Myself, Dr. Irshad, DNB General Surgery second year postgraduate from Sri Ramakrishna Hospital under the guidance of Dr. Sarveshwaran and Dr. Srinivasan, Professor of Surgery, Coimbatore Medical College. I'm here to present a case of breast lump. Moving on to the presentation, it's a 50-year-old female hailing from Coimbatore who is a retired teacher by occupation who was admitted to a hospital with the chief complaints of lump in the left breast for the past 2 months. Moving on to the history of presenting illness, patient was apparently asymptomatic 2 months ago, following which she noticed a lump in the left breast, which was evident during her routine activities like bathing, which was insidious in onset, and she noticed as a small lump which gradually progressed to attain the present size, which is associated with dull aching pain. There is no history of trauma, there is no history of fever, no complaints of recent nipple discharge, no complaints of nipple retraction, no complaints of swelling elsewhere in the axilla or neck, no history of chest pain, no history of breathlessness, cough or hemoptysis. There is no history of abdominal pain, abdominal distension, loss of weight, appetite, no history of jaundice. There is no history of low backache pain, bone pains, and there is no history of convulsions, headaches, and other visual disturbances. Moving on to the past medical and surgical history, there is no history of there is a history of LSCS which was done 30 years ago. She is a known case of diabetic type 2 on oral hypoglycemic drugs for the past 2 years, and she is not a known case of hypertensive, asthma, pulmonary tuberculosis, or any other cardiac illnesses. There is no other abdominal surgeries or breast surgeries in the past. Moving on to the menstrual and obstetric history, she attained menarche by the age of 12 years of age and had regular cycles, that is 30-day cycle with a 4-day flow, and changed around 4 pads per day, which was not associated with any clots or pain. She was married by the age of 22. Her first childbirth was after 2 years of her marriage. She has attained menopause by around 2 years ago. She is a para 1, live 1 with no abortions. She was underwent an LSCS surgery due to fetal distress, and that was the indication, which was exclusively breastfed for 8 months. There is no history of use of contraceptives or hormone replacement therapy in the past. Moving on to the family history, there is no significant family history of breast or other carcinomas seen within the first degree relatives. Moving on to personal history, patient follows a mixed pattern of diet and has a normal sleep pattern. There is no history of specific drug or food allergy seen with the patient. Patient has a normal bowel and bladder habits. Moving on to the summary of the history, a 56-year-old woman, retired teacher by occupation, para 1, live 1, who is a known case of type 2 diabetic mellitus with no significant family history, presented with complaints of lump in the left breast, which is associated with dull aching pain for the past 2 months, probably a left breast lump for further evaluation. So I'm moving to my general.
Can I just come in for a second, please?
Yes, sir.
I would like you to complete the whole examination, but since you have given us a summary at the end of the history, I have 2 or 3 questions that come up.
Yes, sir.
Tell me, when does a breast lump become painful? What is the reason and explanation for pain in a breast lump?
Pain in a breast lump may be due to abnormal development and aberrations, which is called as ANDI entity, where it is associated with cyclical mastalgia, and nodularity is a clinical manifestation. So in that
please
case,
remember, benign disease has pain presenting more often than malignant disease.
Malignant
So when you get benign pain in the lump, kindly keep in mind possibility of benign disease.
Benign diseases.
That's an important thing. A second little request is, what is LSCS? For me, it is lateral subcutaneous sphincterotomy.
Lower
Don't
section.
use those abbreviations, doctor, please.
Yes, sir.
Okay.
Sorry, sir.
It is important. I know you're talking to an educated and known audience, but
Yes, sir.
these are things that we excuse us to. Don't take short forms, just use the full form. After all, it's hardly a second.
Okay.
The last thing is, we are also educated. We all know a little bit about oral hypoglycemic agents. You can say, you can mention the chemical compound that is being used, a metformin or whatever it is. All right.
Okay.
So these are the few little points that I want you to mention. In all breast cases, don't forget to ask the history of back pain and location of any back pain, because that's the commonest manifestation of something going wrong. And that is why it is necessary to mention that also as a negative point. Yeah, continue. Please continue.
Moving on to the general examination. After obtaining consent from the patient and explaining the procedure in a well-lit room, patient is examined with a female nurse as a bystander. On examination, a patient is moderately nourished, well hydrated with an ECOG score of 1. Her pulse rate was 100 beats per minute, regular in rhythm with no specific characteristics. Her blood pressure is measured to be systolic of around 120 and diastole of around 90 millimeters of mercury in the right arm at the heart level. Moving on to her anthropometry, her weight, she was weighed around 70 kgs and her height is 157 with a BMI calculation of 28. There is no pallor, not ectric. She has not no clubbing or cyanosis. There is no generalized lymphadenopathy seen in the patient. Moving on to the local examination. After obtaining consent in a well-lit room, patient is examined with the in a sitting posture, in semi-recumbent posture and lying down posture, with arms by the side of the patient, over the above the shoulder, as and when required. On moving to the inspection part, breast is bilateral breast symmetry is normal with normal contour. There is no other distortion. An upper outer quadrant fullness is seen in the left breast, which is measuring to around 5 into 4 centimeters with ill-defined borders, with no specific skin changes and no dilated vein seen over the lump. Moving on to the nipple areolar complex is normal. There is no discharge from the nipple, no axillary fullness or ipsilateral supraclavicular fullness seen in the patient. On moving to the palpation, patient examined in semi-recumbent position. There is no local rise of temperature or tenderness seen in the patient. A diffuse lump measuring of around 4 cross 4 centimeters, which is present in the upper outer quadrant. Ill-defined borders, which is a mobile lump but is not freely mobile, firm in consistency with no skin changes, and the lump moves within the breast tissue but restricted to a minimal extent, not freely mobile. Skin over the lump is pinchable. There is no fixity to the chest wall or no fixity to the pectoralis major muscle or serratus anterior muscle. On moving to the nipple areolar complex palpation, there is no tenderness, eversion, induration, or distortion of the nipple. A solitary 2 cross 2 centimeters firm anterior group of lymph nodes are palpable in the axilla, which is non-mated. There is no other axillary lymph node swelling seen. No other palpable nodes, no supraclavicular evidence of supraclavicular nodes palpable. On moving to the percussion, there is no evidence of internal mammary nodes seen, which is percussed over the needle border of the sternum. Right breast and axilla are normal. On moving to the spine examination, there is no bony tenderness or deformities seen in the lumbar spine. On moving to the other system examination, respiratory system, bilateral air entry is equal. There is no added sounds. On moving to the perabdomen, is soft, non-tender. There is no signs of liver failure, no ascites, bowel sounds are present. For rectal examination, there are no evidence of deposits in the pouch of Douglas. Sphincter tone is normal. On moving to the cardiovascular system examination, first and second heart sound are heard. There are no added sounds or murmurs. On moving to the central nervous system examination, there is no focal neurological deficit. Moving on to the pervaginal examination, which I have not attempted. On moving to the summary of the case, It's a 50-year-old post-menopausal woman, para 1, live 1, retired teacher by occupation, hailing from Coimbatore, with no significant family history, who is a known case of type 2 DM for past 2 years on oral hyperglycemic drugs like metformin, was presented with chief complaints of lump in the left breast for 2 months, which is associated with dull aching pain. She's moderately nourished with ECOG score of 1 and BMI of 28, and a left mobile upper quadrant lump of measuring around 4 cross 4, firm in consistency, mobility restricted to the breast tissue. There is no evidence of chest wall adherence to, or pectoralis major adherence. There is no skin changes, with a single mobile firm anterior axillary lymph node measuring 3 cross 3 centimeter on left side, with normal right breast and axilla. Parectal and perivaginal examination are not significant. So moving on to the diagnosis, it's an early early left breast carcinoma of T2, N1, and M0, stage 2B, for further evaluation.
All I can say, it's a good presentation, doctor. With this kind of a smooth presentation, you're definitely through the exam already. So
Thank
be
you.
happy. Only thing is you have to practice this little spare things a little bit. There are a few points if I can add to it. It's not that I find fault with it.
Yes.
Remember, this presence of this nurse and attendant that you have should also be there at the time of history taking. There may
Yes,
be
sir.
some aspects of history which a lady may not wish to tell you alone. So keep the nurse even during your history taking. So the attendant should be mentioned. I examined the patient, both history and examination, in the presence of a female attendant. This is
Yes,
just an extra point.
Yes, sir.
You said the pulse rate is 100 per minute. Now,
Yes,
when you
sir.
have 100 per minute pulse rates, there must be something happening. Okay. And
Okay, sir.
that usually suggests either the patient's very nervous and anxious, or there is some pathology. Generally, pulse rates are between 80 and 90
Okay, sir.
in most people. Third point that I had is, you said the mass is diffuse. The
Yes,
borders are little diffuse.
irregular. Yes, sir.
There is a lot of difference. A border is very characteristically well defined or ill defined.
Ill-defined. Okay, sir.
When you can get measurements,
Yes, sir.
it means the borders are well defined. You can
Okay,
measure.
sir.
All right.
Okay,
When you
sir.
cannot measure the size, it diffuse, and the borders are diffuse, you have to give approximate measurements.
Okay,
All right.
sir. Okay,
So
sir.
the words that you use must qualify what you're trying
Right.
to say.
Sure, sir.
The third point I picked up was mobility. You said it is mobile, but not so mobile also. There's a small little extra point you can score.
Yes.
Skin is free, it's not attached to the skin. It
Okay.
is mobile with the breast tissue. There's a
Okay.
small difference there.
Okay.
Some benign lumps, especially the fibroadenomas,
Yes, sir.
can move independently within the breast without distorting rest of the breast tissue.
Yes.
But here you have a lump which is slightly restricted. That means the other parts of breast tissue are moving with the lump. And so that gives rise to the thing that it is not moving separately from the breast tissue.
Breast tissue. Yes, sir.
You followed?
Yes, sir. Yes, sir.
Fourthly, when you give the lymph nodes today, I was recently in one of the discussions somewhere, I think we can slowly shift to describing the lymph nodes in terms of levels.
Okay, sir.
Which level of lymph node is this?
Level 1.
So what
Level
are all the old nomenclatures that come into level 1?
Level 1 lymph nodes are lateral to the pectoralis minor group of muscles.
Right?
Anterior group of lymph nodes.
Only anterior?
And sorry, sir,
yeah, no problem.
Yeah.
Please note, level 1 is a fairly big group of lymph nodes in that it includes the posterior,
okay, sir.
central, and anterior lymph nodes.
Okay.
Everything that is lateral to the lateral border of the pectoralis minor, pectoralis minor
Yes, sir.
is considered as level 1.
Yes, sir. Okay, sir.
The deeper layers and nodes of central group that go under the pectoralis
Pectoralis
minor,
minor.
they are called level 2. And
Okay.
the apical nodes that we used to call apical before, which is on the medial side of the pectoralis minor, is called level 3.
Level 3.
So that is the little distinction nowadays they are giving up. Keep it in mind. If the examiner asks you, you'll be ready to answer.
Okay, sir.
Right. The next thing was that in your examination, you
Yes, sir.
gave a complete examination. How, this is a very, very old question, old thinking. Today
Okay.
we don't do it, but when you percuss for your mediastinal lymph nodes,
Yes,
you
sir.
said alongside the sternal border, I agree.
Yes, sir.
But which spaces?
Palpated over second and third intercostal.
Percussed over, not palpated.
Oh, sorry. Percussed over second intercostal space.
Mm.
And second and third intercostal space.
Yeah, 2, 3, and 4. All the three spaces can have the lymph node enlargement if it is occurring there.
Okay. Okay. Thank you.
You examine the respiratory system for what?
For evidence of metastasis.
What metastasis?
If there are cannonball metastasis, when it
Can
involves.
you pick up cannonball by clinical
No,
examination?
clinically, I just wanted to rule out whether there is a disparity in the air entry levels on both the sides. Any.
What does the disparity give you? What indication? Right side is less than the left side.
Any
Yes, sir.
consolidation? Yes,
What
sir.
type of metastasis occurs? Is it cannonball or is it the something collection in the pleural cavity?
Sorry, pleural effusion is.
Yeah, that is
That's
pleural
what you
effusion.
should examine.
pleural
Doesn't
Doctor.
affect the lung parenchyma. That is what.
Parenchyma.
So you should answer it as pleural effusion.
Pleural effusion.
Pleural effusion.
Okay.
Yes, sir. Thank you. That's what I was going at. The
Hmm.
most common metastasis of breast tissue
Breast tissue.
malignancies in the chest is a pleural effusion.
Pleural effusion.
Generally on the same side, sometimes on the opposite
Okay.
side. Okay, and the it is made out by difference in air entry or and dullness on percussion on a particular side, which tells you that there is something occupying space over there. You cannot detect cannonballs sorry, by themselves in a clinical examination unless they are very big and they cause some other changes. So this is another common mistake. Everybody says breath sounds are equal. It is the air entry should be equal, and that you are having no concomitant dullness where the air entry is not well heard.
Okay.
Tell me why and how does the malignancy reach the pleura? How do you get a pleural effusion in breast carcinoma?
Involvement of chest wall further leads into pleural distortion causing pleural effusion.
That's not the mechanism.
Hematogenous.
No.
I'm sorry, sir. I don't know.
Yeah. Again, when you don't know these things, please quickly say you don't know so that we can move on. Pleural effusion occurs from two things. One is diffuse lymphatic, retrograde lymphatic permeations, both from chest wall lymphatics in early cases, and in late cases when mediastinal lymph nodes also get blocked, congested and blocked, there is retrograde. There's no lymphatic flow out of the chest, and that gives rise to metastasis, pleural effusions. So you can occur from the chest wall side as well as from the mediastinal side as a reason. Why you examine abdomen in such detail?
Per abdomen, I just wanted to include liver mets, ascites, which is also a feature. So for all this, I just wanted to do a para-abdominal examination.
That's all? If she was 40 years age.
40 years age. Krukenberg's
this lady is also menopausally, I mean, she's also menstrually active. She hasn't hit a menopause yet. It may be perimenopausal. So it's very unlikely. But in the younger age groups, they say that there is an incidence, a very small but low incidence of a direct spread of a spread to the ovaries. How does it reach the ovary?
Transilomic spread. So
Transdiaphragmatic lymphatics, the translymphomas, two.
they'll
And where on the ovaries do these settle?
settle in the pouch of Douglas.
No, 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 no.
Mhm.
On the
Ovary.
ovary,
Ovary.
where does the tumor stand?
Uh, sorry, sir, I don't.
Again, where they have shed the corpus luteal areas where there has recently been a shed of an ovum
Okay.
due to the period, and there is a raw area, these tumors go and implant over there. So that is why you need menstrually active people for this disease to be.
Okay.
Out of interest, do you know what medical profession Krukenberg was? This is just for fun.
Sorry, sir, I don't.
Krukenberg was an ophthalmologist. I don't know
Okay.
why he was looking at the pelvis, but he's a fellow who described it. But he was basically an ophthalmologist. Okay, leave that. Sorry. About your bone tenderness, which is the bones you felt for?
Examination over the lumbar spine.
And
Uh, lumbar. Sorry, sir. Only I
No.
examine lumbar spine.
What are
how
the
do you
bones
assess
usually affected? Usually, one is lumbar
Clavicle.
spine. One is lumbar spine and the
Clavicle.
No, no.
Any long bones?
Femur.
Yes,
Yes, one more.
one more.
Humerus.
Yes.
Can be humorous, but the mnemonic that you should remember is LFT.
Yeah.
Lumbar spine,
Lumbar.
head and neck of femur, and thoracic spine. Okay.
Okay.
Once again, how does the metastasis reach the spine?
To the posterior intercostal veins, to the bastion plexus of veins, where
How-
lumbar.
Why does it go that way? What pushes the cells in that direction?
Um,
Normal
Normal.
respiratory pressures,
Pressures,
inspiratory
okay.
pressures, and coughing and moving.
Okay,
The
sir.
raised intrathoracic pressures tend to push tumor emboli along these veins into the
Bastion plexus.
basal venous plexus, where they can settle. In which part of the vertebra do they settle?
They settle the body of the vertebra.
How can you make it out?
On X-ray, we can make it out by osteopenic and deposits.
Generally, the X-ray finding that is typical of CA breast is a damage to the pedicles of the vertebra.
Okay.
But it is correct, the tumor cells do settle down in the body of the vertebra, giving rise to either osteopenic or osteosclerotic secondary, and that is how it is. And in your clinical examination, it is not so much the spinal tenderness as a little paraspinal tenderness that you should do. Okay, just don't do only on the spine, do both sides of the spines, and then you may pick up tenderness. Now, all this examination is very important in a case of LABC, locally advanced breast carcinoma, where you have to really look. In early breast cancer, as in this case, it's not necessary to be in such detail. But since we are here for an hour of discussion, I am taking liberty of asking you these questions.
Okay, sir.
Okay. Right. Come back to the base. What is your clinical diagnosis and staging?
Early left breast carcinoma of T2N1M0, stage 2B.
So in this situation, I hope you all are very well aware of your T classifications.
Yes.
There are a few organs in which you should know your T&M staging. Oral malignancies, breast, stomach, colon, prostate are the main ones in which your T&M classifications will come in. And please learn, each one has a few variations. Can you give me the end stages of breast carcinoma? What is the latest for the end stage?
N staging, latest one is NX is no regional lymph nodes. N0 is
NXs cannot be assessed. No?
NXs cannot be assessed. N0 is no regional lymph nodes. N1 is metastasis to movable ipsilateral level 1 and 2 axillary anti-axillary lymph nodes, and N2 is divided again into N2A and N2B. N2A is metastasis in the ipsilateral level 1 and 2 lymph nodes, which is fixed to one another. That is mated.
Yes.
Mated nodes. N2B is metastasis only to the clinically detected ipsilateral internal mammary nodes in the absence of any clinically evident level 1 and 2 anterior axillary nodes.
Correct. Very good.
N3 is a metastasis to the ipsilateral infraclavicular group of infraclavicular lymph nodes, and N3B is a metastasis in ipsilateral internal mammary nodes and anterior axillary uh, nodes with the supraclavicular without supraclavicular involvement.
Okay, fine. What are Rotter's nodes?
Those are interpectoral nodes, are called as Rotter's nodes.
Yeah. All right. Fine. Please, these are all those little questions that come up. Very rarely we ask about T staging. Everybody gets caught on N staging. Well done, doctor. You said it correctly. That's good for you. Okay. Tell me how you will proceed on this case. She's come to you. Now, what would be your next step? Clinically, you're all right now. So,
yes,
what do you do?
after my clinical examination, I would just want to go with the radiological examination. I would want to perform a bilateral mammogram to look for the architecture of the tumor. Then I would want to perform a true cut biopsy, which would confirm my ER/PR status of the tumor, and which gives a guide regarding the histology of the tumor. Then I would want to proceed with the breast conservation surgery, as it is an early breast carcinoma.
Yeah.
And followed by, I just wanted to give a radiotherapy depending on the lymph node status.
Oh, if you are saying early breast carcinoma and lumpectomy, you have to give radiotherapy.
Yeah, that's what radiotherapy is mandatory.
Don't consider it is once you're committed to breast conservation, you
Yes,
have
sir.
to irradiate the remaining breast.
Yes.
Okay, let's go step by step. Will you do ultrasound or will you do regular mammogram?
For this patient, as it is an old patient, I would just want to go with a mammogram. If it's a young patient with a dense breast, I could go for an ultrasound.
Very correct. Yes,
Yeah.
that is correct. And you can even use that for guiding.
Guiding. Yes.
What is mammographic localization called? What is that instrument? How do you do mammogram? With the mammogram, you use to get biopsies of suspicious areas. Do you know the word for that? Do you know the
Xenograph.
machine that is used?
Xenograph.
No, not
Sorry,
it.
sorry, sir.
We use something called the mammotome.
Mammograph.
Mammotome gives you stereotaxic mammographic images, which
Okay.
helps you guide your, that is for needles, which helps
Okay.
you to guide the needle to get you sample tissue. So stereotaxic. Now they've all gone out of road because we are now needing a core of tissue.
Yes.
And so the primary first invasive investigation is the true cut needle biopsy or CNB, core
needle biopsy.
Okay. Now, how do you do a core needle biopsy?
For a core needle biopsy, we use 18 gauge needle. Have to fix the lump in the breast, and after infiltration of the local, we make a small incision, and using 18 gauge needle, around 6 to 7 samples are taken. All the samples has to.
You mean you pass a needle 6 to 7 times?
I'm sorry, sir.
And is it an 18 gauge what needle? Just an hollow needle?
Hollow needle, yes.
No, I don't think so. You need to cut out some tissue. No, it is a true cut biopsy needle. True cut. You need to get a cut of tissue, a sleeve of tissue, a core of tissue. Just by aspiration in an 18 gauge, you won't get. So it is an 18 gauge or 16 gauge true cut biopsy needle that you need. Okay.
Okay.
4 important points. Fix the lump.
Yes, sir.
Give local anesthetic.
Yes, sir.
Make a small skin incision with the point of a 11 blade. Small one.
Yes.
And then direct your needle into the lump. Because if you don't make that the skin incision, when you penetrate, you may penetrate too deep. And you may not, you may just say, of course, this is an invasive procedure, so consent of the patient to be taken. And you can pass the needle up to twice. Don't take too many sleeves because then you will cause local hematoma and other things.
Hematoma.
So
Okay.
2 passes of any. Unlike FNAC, FNAC is a 23 gauge needle, minimum of 6 passes, and an aspirate that is done during each pass. So the cell yield is different from the tissue yield. Here you're looking for tissue.
Yes.
To get a satisfactory tissue, that is enough. Okay. So please remember, consent, fix the lump, local anesthetic, small skin incision, use a core needle biopsy. And get it. Why do you want this core needle biopsy, doctor? What is so special about it? I'll do it with the FNAC only, no.
With the core needle, we can able to get a tissue through which we can assess the ER/PR status, which would be guiding us in terms of any neoadjuvant therapy and also adjuvant therapy, adjuvant chemotherapy.
With the advances in therapy, our treatment strategies are dictated by the type of tumor the patient has. And today we can assess and get that patient information before we start treatment. Formerly, we never had all this. Directly, we did mastectomies and then the specimen, and then it came, and then we decided what to do. So here we have the opportunity to be able to plan and strategize our treatment regimes. That is why core needle biopsy has now replaced FNAC. I'll just ask you, what is the role of FNAC in a breast lesion? When will you do FNAC?
In case of benign breast diseases,
Yes.
or and
benign, they're now going core needleman.
Then we'll, in case of any cystic lesions, to aspirate.
Okay. The main use of the FNAC is to confirm. Some people want a confirmation of the lymph node status in the axillary.
Okay.
Okay. Some people will say you can do an FNAC of the lymph node to see if it has gone metastasis or not. Secondly, FNAC is very useful when you already know the diagnosis and there's a recurrence. Recurrence of a lump in that region, you need not do a true cut, you can just do an FNAC. So the role of FNAC is coming down. The main role is true cut biopsy. All right, you got that much. What is the difference between, why did you do mammogram of the same side?
I would want to do a mammogram of same side to look for the architecture of the tumor, and also other any macrostic and microstick lesions are there, present or not. And I just wanted to know the level of calcification. There is an extensive calcifications. It is more towards the locally advanced breast carcinoma. So
you got locally aggressive breast carcinoma.
Sorry, locally aggressive breast carcinoma.
Yes.
So to rule out all these other architectural changes, a mammogram will be more effective.
What's the difference between multifocal and multicentric?
Multicentric disease is occurring of various lumps in the same breast. Multifocal is occurring of in both the breast when there are lesions present.
No. In the same breast itself, lesions in the same quadrant.
Yes, sir.
The second lesion in the same quadrant is multifocal. Yes, but whereas it is other lesions seen in the rest of the breast tissue, other quadrants is
multicentric.
Okay, small differences, but these are the things that they keep asking you, so you must know the difference. Yes, don't make that mistake.
Yes, sure.
Why did you do mammogram of the opposite side?
I would want to do a mammogram of opposite side for detection of whether it is a primary breast carcinoma or is there any other consecutive tumors present in the other breast also.
Can you give a little better explanation? Why you do it on the opposite side? A simple reason is there is a 10 up to 5 to 7%, in some people even more, incidence of bilateral breast carcinoma. Okay, can you tell me which tumors are bilateral at presentation?
Medullary carcinoma.
The lobular carcinoma.
Lobular carcinoma.
And when you have a familial history,
Yes, sir.
then
Yes,
you have a chance of having it bilateral.
bilateral.
So one of the reasons is that it is better to do the mammogram. It is always a must to do the mammogram to know the architecture and the status of the
Status of
opposite
the
breast.
opposite
Yes,
breast.
that is the reason.
Okay.
As also what are the mammographic images, or what are the shadows cast by a malignancy? How is it different from a benign lesion? By looking
In
at mammogram itself, we can tell it is
yes.
malignant.
In malignance, there is a dense distortion of the architecture, irregular borders with pleomorphic clustered calcifications. These are all evident of malignancy, whereas a benign lesion is also speculations will be there in malignancies. Yeah, in a benign lesion is rounded and it's not dense.
Okay, very good. Yeah. So that is it. And there's another small little thing.
Yes.
In our days, it used to be very good. It was called Labon's law, in which the mammographic size of the lesion is smaller than the palpable size of the lesion.
Okay.
Because when you palpate, the induration of the surrounding tissues also gets involved in your measurement of the size of a lesion. Whereas in mammogram, the actual cord lesion would look a little smaller than what you palpate. That was somebody's law at that time, but now it's not so accurate. But it is important to know it is spiculated, it is calcified, micro and macro calcifications can be seen, and also presence and absence of cystic and other changes in the rest of the breast. So that is why you do the mammogram. Right. Um, you've done the mammogram, you've done the core needle biopsy. We'll come to that. Any other questions? Hello?
Hello, sir. Hello.
Hello? Can
Am
you
I
hear me?
Am I audible, sir?
Yeah.
Hello.
Hello?
Yeah. Yes, sir.
Can you hear me?
Yes, sir. I can hear you, sir.
Yeah. Okay. Um, right. So I'm saying, what other investigations will you do?
Even it's an early breast carcinoma, I would also, after from the history, I would want to do a chest X-ray and a USG abdomen as a part of metastatic workup. Followed by, I would want to take the patient for breast conservation surgery.
Okay. Before you, what is the metastatic workup you will do?
As a part of metastatic workup, I would want to do a routine chest X-ray and USG abdomen.
For what?
USG abdomen to detect any liver metastasis, any other peritoneal deposits, Krukenberg's deposits,
Yes. Yes.
um, level ascitic fluids if present. All these can be assessed in an USG abdomen. So as a part of
Yeah.
metastatic workup, I would want to do it.
Okay.
Then if bone pain is evident, then going for a bone scan, technetium-99 bone scan is needed to localize the bone lesions.
Yeah. It is generally recommended that you do not do a bone scan unless there is symptoms in the early breast carcinoma. Okay. But in every case of locally advanced, you may have to do it.
Okay.
I'll ask you two questions. What is the role of MRI?
MRI in breast is seen in high risk group of patients with familial breast carcinomas, and it
Very
is
good.
seen when there is a multicentric or a multifocal disease, and
multicentric disease.
Yeah, multicentric disease, and in patients with implants, MRI is an indication.
Yes.
And in implant ruptures and implants associated, MRI is an indication. So that's all.
MRI, there are three indications. One is when you have multifocal or bilateral involvements. Secondly, it is breast which has a prosthesis in it. And thirdly is when you are evaluating breast lump in pregnancy.
Pregnant.
Okay, so these are the 3 times when you use MRI. Can you hear?
Yes, sir.
Hello?
Yes, sir.
Can you hear? You heard
Yeah,
what I said about MRI?
yeah, yes, sir. Yes, sir.
Oh, those 3 indicate.
Those is.
Now the patient's husband is educated fellow. He says, please do PET scan for my wife. Will you do it?
PET scan, it's not necessary in an early breast cancer patient, provided with there is no high risk family histories. So in case of locally advanced breast cancers, uh, PET scan is effective to know the distant metastasis in an inoperable LABC.
Yeah. There's another little point about breast bone secondaries. You've done your LFT, isn't it?
Yes, sir.
If your alkaline phosphatase is highish, not very high,
Okay.
and if your serum calcium is high,
Okay.
one should think of a possibility of a breast metastasis, bone metastasis.
Bone metastasis.
All right, just keep that in mind. So I always say serum calcium levels to be monitored in all cases of, estimated in all cases of breast. But that's not recommended, but it is one of the useful things to do.
Okay.
Now, you want to treat this patient. How will you counsel her? Advantages, disadvantages of
breast
amputational surgery like MRM versus conservative surgery like breast conservation. How will you discuss it with the patient?
In case of early, as in this patient, it's an early breast cancer. So we can counsel her regarding breast conservation, followed by the radiotherapy, the disadvantages of it causing discoloration. Everything will, has to be discussed to the patient. The importance of radiotherapy, which is mandatory, has to be informed to the patient post surgery.
So the main thing is the availability of radiotherapy facility. Okay, many centers out in the periphery, when we are in second and third level cities where there's no radiotherapy, we are still forced to do something else. Unless you are sure of a radiotherapy follow-up, you are not supposed to be advising. So this is more an urban phenomenon of conservating breast. Many people still have to agree to the routine mastectomy.
Modified radical mastectomy.
Right. When you're doing the breast surgery, what is the role of lymph node? I'm sorry, you're doing breast conservation surgery. What is the role of sentinel lymph node biopsy? Or how do you do it?
Sentinel lymph node biopsy in an impalpable lesion, that is any T with N0 lesions. Hello, sir.
Yes.
Yes. You stop your slide sharing. You stop your slides.
1 second.
Yes, now you speak to.
Yeah. Okay. Yes, better that way.
In any impalpable lesions, sentinel lymph node biopsy is done. If the sentinel lymph node biopsy comes to be positive, axillary dissection has to be performed up to the level 3 nodes.
Traditional AL and DA. No, not up to level 3, just that. If it is just an indicator of whether you'll go into the axilla or not. Okay. Will you do a sentinel lymph node biopsy in this case?
No need, sir, because in this patient already there is a solitary anterior group of lymph nodes of level 1 positive. Yeah. So here axillary dissection is mandatory.
Yes. Okay. Fine. So when you have an N0 status and you want to assess the early spread, you do it. Can you tell me how you do sentinel lymph node biopsy?
Sentinel lymph node biopsy, indocyanine green dye is injected 45 minutes or prior to the procedure. Using gamma cameras, it is being.
Indocyanine is not gamma camera.
Sorry. Sorry. In our institute, we install technetium 99, followed by.
Two methods. One is either you do the radioactive method, the nuclear medicine method, where you have to have a gamma scanner, probe and scanner, or you inject the dye, indocyanine or even methylene blue is injected. and it is there is a little rule that you inject up to 5 ml, 5 centimeters around the lesion, 5 ml, wait for 50 minutes, and then do it, and then you get your lymph node
Lymph
coming up
node.
positive. Okay. Yes, sorry. You'll do massive. In this case, what kind of incision and how will you deal with do your surgery?
Incision, elliptical incision, modified Tourette's incision has to be performed, including the, sorry, in case of breast conservation surgery, I include the tumor with the margin of healthy breast tissue, leaving the nipple areola complex.
We conserve nipple areola,
Complex.
and your incision is dictated by the contours of the breast, if it is on the medial side, and on the lateral side, the lateral quadrant, you try to contour it towards the axilla so that you can include the axillary dissection in the same incision. All right. In this case, this is an upper outer quadrant mass.
So
it is away from nipple areola complex. There is no evidence of involvement of nipple areola complex, so they can be conserved nicely. And you can take a little elliptical incision going upwards and laterally into the axilla little bit, and you can do your axillary clearance also. Okay, so that will be it. How will you, what are give me the few steps of how you clear the axilla. ALND, axillary lymph node dissection.
Axillary lymph node dissection limits superomedially the Halsted ligaments, inferiorly till the angle.
You use Halsted ligament. Now tell me, what is Halsted's ligament?
Yes, you are getting into trouble.
You
are getting into trouble. Professor, see, always examiners ask question, you listen to the question. He asked the boundaries of the axillary dissection. So, in the axilla, what is the boundaries? Why do you want to go to the Halsted? So now he is caught up with Halsted's ligament. Now tell what is Halsted's. Now Halsted's ligament, you tell me.
Sternoclavicular ligament.
No. Costoclavicular ligament.
Costoclavicular ligament.
Is that coming in the axilla?
No, sir.
Why? See, you are digging your own pit.
Yeah. That was important in our radical mastectomies when we were doing radical mastectomy.
Okay.
So be careful on what you say, doctor. Okay. Very important to practice these things, practice saying these things so that you don't use unnecessary words. Huh?
Okay.
And don't be premature in answering the question. You want to tell me you know about Halsted ligament? Know it good, but if you get caught by not knowing it, it is worse for you. No. So stay cool. Okay. Boundaries of dissection, axillary dissection.
Inferiorly by the angular vein, medially the medial border of costoclavicular ligament, and inferiorly till the lower border of clavicle.
Inferiorly lower border of clavicle? No, you got all confused. Yes, tell me what lymph node groups you clear, doctor. That's enough.
Level 1 and level 2.
Yes. What is the structure that you will guides you in your clearance?
Pectoris minor muscle.
Minor muscle. Yes. Yeah. And on superiorly, the upper extent, what runs?
Axillary vein. The superior limit is the axillary vein.
Very good. Correct. So that is it. It's superior. What are the nerves that you will encounter?
Two nerves. There is a lateral thoracic nerve of bell. Hello.
Yes.
Yes.
Nerve to serratus anterior.
No.
Hello.
Thoracic. That is one nerve. Which is the other one?
Nerve to latissimus dorsi and
yes.
And lateral thoracic nerve of bell.
Yeah. Where does nerve to latissimus dorsi come from? Which cord of the brachial plexus?
Posterior.
And where does?
Sorry, sir, I don't know.
Please read your brachial plexus. This is where you get caught. You see, this is a simple case. We will be discussing. We want to see your overall knowledge.
Okay. Sir.
and they'll ask you these little questions. So you must be aware.
Okay.
The thoracodorsal nerve is a branch of posterior
Branch of
cord, and long thoracic nerve is the direct branch from the plexus. It's not from the cord; it is directly from the brachial formations. So that is a difference in the two. The long thoracic nerve of bell lies in the floor of your dissection, the depth, and that is the. If you have seen it, that means you've done enough. Okay, but
Okay,
don't
sir.
cut it. Some people say you can even identify the intercostobrachial
Brachial nerve.
and the medial and lateral pectoral nerves, which come in the area of dissection in the cases. If you can see them, identify and preserve them.
Okay.
All right.
Okay.
What are the, will you drain your axilla or not? Will you put a
Sir,
drain?
I can't get you, sir. Hello?
Will you put a drain or not?
Drain is necessary, yes, sir. Because when we remove two groups of lymph nodes, chances of lymphedema are more. So reactive lymphadenitis will be
Ooze, lymphatic ooze.
too.
Yeah.
So drain is necessary and is ideally kept for 14 days.
No, it's not ideally for it is kept up till the discharge is less than 25 ml per day. You can remove it. Once, if it does not reduce to 25 ml per day, after 14 days, you can remove it directly. But it's better to keep it till the discharge comes down. And it should be a vacuum suction drain, not just an ordinary. Okay. Yeah.
Okay.
All right. Then the report comes back to you and says it is HER2 ER positive, HER2 negative.
ER positive tumor is a hormone response tumor. So we start the patient on tamoxifen. Hello, sir.
Yes, yes, please continue.
Tamoxifen is initiated. The therapy is continued till 5 years, and again it is assessed.
You mean you're not going to do the, you're not going to give the radiotherapy?
Radiotherapy has to also be given, sir. In ER positive, I would want to give tamoxifen followed by radiotherapy.
Okay. Yeah. No, you will give radiotherapy followed by tamoxifen.
Sorry, okay, sir. Radiotherapy followed by tamoxifen therapy.
ER positive, PR positive, HER2 positive.
In such cases, I would want to go with tamoxifen and trastuzumab. HER2 new positive, so I would also want to administer trastuzumab. Radiotherapy followed by.
If you have the facility, yes, you can do that. But if it is just when it is so hormonally sensitive, simple tamoxifen or hormonal manipulations can be done. Any better drug than tamoxifen?
Postmenopausal women.
Postmenopausal.
Letrozole can be given.
Yes, letrozole or anastrozole can be given. These are aromatic enzyme inhibitors.
Okay.
These don't act on estrogen sites. The tamoxifen acts on estrogen receptor sites. But these aromatic inhibitors prevent the formation of estrogens, and they act at a different point. So the side effects are much less, and so they are safer to use for a long term. It comes as ER negative, PR negative, HER2 negative. What will you do?
It is called as basal cell type, where all the 3 receptors are negative with the worst prognosis. Here we go with again we have to keep the patient in surveillance. Radiotherapy followed by chemotherapy is indicated.
There is no doubt about it. You have to give. These are the ones with a poor prognosis.
Yes,
and so they have to go up to 12 cycles of chemotherapy of standard drugs, see the response, and then give the second line drugs also if necessary, because these are the worst prognosis. Okay? So this is the different combination. You can get triple positive. There's no such condition, but all the things being positive, it's easier to treat. Triple negatives are very difficult to treat. And the in-between ones of where one side is positive and the other is not available, you have to use your combination therapies.
Okay, sir.
Okay. Anything you want to say beyond this?
Uh, uh,
Any questions to ask?
Anybody from the audience?
Yes, sir. We need to ask few questions, sir.
Yeah, please.
Yes.
Sir.
Yes, sir. In early breast cancer, NCCN guideline is not even mentioning to do a chest X-ray or ultrasound scan, sir. So, can we stick on to that in exams, or we need to mention in chest X-ray and ultrasound scan?
Kindly note my words, doctor. You are doing the general surgical examination. And for principle of all malignancies in general surgical levels, the chest X-ray is mandatory in the workup. Whether stomach or prostate or thyroid, you will do a chest X-ray as part of your workup. I agree, NCC does say that you do not need to do a chest X-ray. What big saving are you doing by that? If you are in an oncology center where everything is controlled, yes, that is correct. But is a general routine, and for the purpose of the exam, kindly mention chest X-ray also. This is my feelings. Srinivasan sir, do you agree?
No, what you said is 100% correct. See, the textbook, the standard, certain standard investigation which has to be done, and in the exam, don't quote anything. See, this is X-ray chest is a routine. One is for looking out for the pleural effusion. Number two is for anesthetic assessment, as the patient has got any COPD. Now, what he forgot to mention was X-ray spine. You forgot.
Yes.
No, ultrasonogram. Ultrasonogram is routinely done. See, in the early breast cancer, we do not know unless you do an ultrasonogram or unless you do the trocar biopsy. The biopsy report comes, we do not know. So, and we can, as a routine, you have to do the basic investigation. Don't quote any guidelines. So the standard examination is a must. Of course, as Professor said, the CT, the MRI, or the PET scan, or the bone scan, or will come later. But the basic investigation should be done for any case. If you leave the basic and straight away go for bone scan, then you will be penalized. So always the basic investigation you say first. That is very, very important. As I said, serum alkaline phosphatase, serum calcitonin, the blood urea sugar for the anesthetic purpose, the serum creatinine, the LFT to look for the liver function. All these things has to be done routinely. As you said, a trocar biopsy. So don't say that gives like this. As a postgraduate, until you pass, you say X-ray chest and ultrasonogram.
Thank you for the patient answering, sir. So one more question.
Yes.
So is there any stage to do the CECT, or we are doing in any cases? So what is the stage indication for CECT, sir?
Locally advanced breast carcinoma. When you're having locally advanced breast carcinoma, you want to know mediastinal details in greater dimensions. Then you do your CECT, that is contrast enhanced CT. A plain CT just to detect malignant nodules, presence or absence, is enough. Is the next qualifying after chest X-ray. CECTs are all done when the disease is a little more advanced. Again, I find that is splitting hairs. What's the difference between a CECT and a plain CT? Plain CT gives you enough parenchymal details to, which is called HRCT also, which gives you the presence or absence of nodules in the chest. But when you're looking for mediastinal lymph nodes and other things, you need to do a CECT.
Thank you, sir. One more question, sir. That you said in corneal biopsy, we need to take at least 2 samples. Some books are mentioning it's 6 to 8 samples, sir.
Again, it depends on the damage you're doing, doctor. Because if it's a small lump and you're doing repeated biopsies, I don't know. I've seen enough and more hematomas and bleeds that occur, which cause a lot of distortion of tissues. And when you go back in to do the lumpectomy, you have such a big hematoma around that you don't know exactly the margins of the growth. So I keep telling them 2, maximum 3 passes. In a center where they are doing more, you cannot fault it because you want more tissues. But 2 samples is the least. 2 passes is the least. Anything more depends on the adequacies of the tissue that you're getting. In 2 passes, you get 2 lovely sleeves of tissue. It's enough. You don't need to do 6.
You have
When there's doubt in tissues and other things, you can do more passes.
you
Yes.
have answered my question, sir. Thank you very much.
Yeah. Thank you.
I'm calling from Sri Lanka, sir. I'm listening to you.
you. Greetings to you. I hope the weather is good there.
Yes, sir. It's fine, sir. Yeah, it's fine, sir.
Good. Right.
Thank you, sir. Thank you for
Just to complete this discussion. Patta, sir, is my screen on? Can I move?
Yes, sir. Yes, sir. It is on. It's on.
Okay. Now that we've had a little discussion on breast.
Karuna, you have a question?
Yes, sir. Sir, I was just asking, in a post-menopausal women with stage 3 breast carcinoma, where when we are planning for neoadjuvant, which is strongly ER positive, so how would we, since it's going to be a poor response to chemotherapy, is there, how do we choose the neoadjuvant therapy in that case? With axillary lymph node positive, do we still go ahead with chemo alone, or is there a role for, as per the new guidelines in Schwartz and all, many journals, they say that neoadjuvant endocrine therapy can also be initiated. So how do we approach that particular case, sir?
Unfortunately, the permutations and combinations of breast carcinoma, type of disease, grade of tumor, response to hormone and all are so varied. You have chosen a very small, rare possibility of a postmenopausal lady with a hormone-sensitive tumor, which is having poor biological markers, where you have to decide on chemotherapy. The standard teaching at our level is that at postmenopausal, you start anti-estrogen therapy, hormone therapies, and then decide whether you will give chemotherapy or not concomitantly. The primary tumor needs to be excised, and then you decide on the facility available, the economic status of the patient, and the ability for you to conduct a follow-up on the patient. So that all is individual. There's no strict rule and guideline on these things. Everybody will have his own way. See, I have my own way of combing my hair. I have no hair on my head, but I still have a way of combing. The gentleman, Dr. Ishrat, presented, he has a lovely mop of hair. He has his own way of combing. We both have hair on our heads, but it's different for the different situations. So we can't have one rule to encompass all. We have general principles. And general principles above 70 years with hormone positive means you use hormonal management as one of your strongest tools in the management of that patient.
Okay, sir. So if the same patient would have been a premenopausal woman, how would the approach
Then
be?
you have to choose your chemotherapy, the most aggressive forms of chemotherapy that are there. You start with standard drugs. In 3 cycles, if you have no response, you have to move on to second line drugs, the taxanes and other medications.
Okay, sir. Thank you, sir.
Yeah. Right. Now, I just will complete this little examination.
With your permission, may I leave, sir, because I got some work.
Yeah, right, sir. You please, sir. Thank you very much for your presence. Sir.
Thank you, Radhakrishnan, sir. Thank you.
Thanks.
Thank you.
Dr. Radhakrishnan, can I continue or should I?
Yes. No, there's 1 or 2 more questions. Parthivel, what is your question before sir starts his lecture?
Sir, good afternoon, sir. Sir,
Yeah,
actually, a 50-year female after getting this neoadjuvant chemotherapy, sir, if the patient is getting amenorrhea, how to identify, sir, whether it is chemotherapy-induced amenorrhea or whether she attained menopause, or how to differentiate it is a natural menopause or it is due to the chemotherapy-induced menopause, sir?
Why do you want to differentiate? What difference does it make?
Sir, after if it is a natural menopause, then we cannot use this. If it is natural menopause, we have to use aromatase inhibitors. No, sir, we cannot use tamoxifen. So if it is due to chemotherapy-induced amenorrhea, can we use this tamoxifen, sir?
Again, it is a very split-head question. It is correct that if it is menstrually active, you use aromatase inhibitors. Wait and see, there's no particular thing. I do not know the answer to that question, I'll honestly tell you. So I have not come across that situation. Yes, in all forms of chemotherapy, there is a chemotherapy-induced period of amenorrhea. Whether it's the natural amenorrhea happening or a natural menopause occurring or not, we'll have to wait and see. There's no particular way in which you can take it. In the meantime, your other therapies will be going on, no? Your chemotherapies and other things.
Sir.
There's no hurry to start the treatment. Younger the patient, the more emphasis is towards the chemical chemotherapies. The older the patient, the emphasis shifts towards the hormonal therapies.
Okay, sir.
Yeah.
Okay, sir. Thank you, sir.
Tell me.
Yes, sir. Yeah.
Okay. Right. Now, in a breast carcinoma examination, I keep giving you a little few tips. Please remember the essentials of examination include the preparation. That is, you need a female attendant with you. Make sure you've washed your hands today with sanitizer or soap. Introduce yourself and the attendant. You identify your patient to make sure you're examining the right patient in the exam. I've had the situation where somebody said go and examine the patient, and he went and examined the abdomen of the patient, but actually it was a breast case. So there are little things that happen that can slip up. Confirm that it is the right patient. Explain and get your consent. If it is a painful lesion, always tell them, are you having pain or not? If it is having pain, tell them that during the examination, there may be pain. You will have to allow us to proceed. Ensure the privacy and the exposure. At the end, don't forget, please thank the patient. Please make sure that they are comfortable and dressed in comfort before you take off the screens. And then clean your hands and then go. And if you're having a stethoscope, hang it around your neck, but don't keep, fold it around your neck or the back of your neck, or don't keep it hanging like a loose thing in front during the examination. During the discussion with us. The history, yes, the history was adequately given by Dr. Irshad about nipple and nipple discharges. There were plenty of specific questions to be asked in a breast, but remember, the main emphasis is to see whether there was any predisposition to the development of a breast carcinoma. And the corollary to remember is that a breast denied of its function is more prone for malignancy. And that the only clearly proven protective factors are the fact that the patient had a first child before the age of 21, and there was at least 2 years of total breastfeeding time during her life. 2 children or 1 child or 3 children, then we get more and more protected against a breast carcinoma. The nulliparity, the age at menarche, the age at menopause, the cancer, history of cancer in the patient, and the time of pregnancy of the first child are all important. So I just put them together, NAACP. These are the questions that you should ask. Make sure that you've asked. Remember the 4 P's of examination. You should know the 4 positions. You should use the palms of your hand, fingers, and the palmar surfaces of the hand to feel the patient. Don't pick up the node. Don't pick up the swelling. Then you cause pain and you cause difficulty. Palpations that are often forgotten, so do not forget. Supraclavicular lymph nodes, mediastinal lymph nodes. It looks so obvious here, but in the tension of the examination time, you tend to forget. It's very commonly occurs, and then you find that you've missed it. So make it a habit that you go from the breast to the axilla to supraclavicular, opposite breast, opposite axilla, opposite supraclavicular. Make sure that the whole sequence is done properly. And look for the metastatic spread. It is the pleural effusion, the abdominal liver palpation and ascites, sometimes rarely premenopausal and pelvic mass. Bone tenderness for lumbar vertebra, hips and necks of the femurs, and the thoracic vertebra. They are the roots of spread. And for each of these, you should know how the malignancy reached those particular areas. Nipple nipponics in breast, always remember the nipple can give you an indicator of many diseases, many things going wrong. So if you have these changes on the nipple, which are called the 7 Ds of discoloration, discharge, depression or retraction, deviation, displacement, destruction or duplication, they mean there's some pathology in that. And a nipple change of carcinoma is an ABCDE change where it becomes asymmetrical, it bleeds, there is some circumferential retraction, there's a destruction of the nipple in some cases, and sometimes you find on the positions of the breast, you find the nipple being elevated from the opposite side. The causes of nipple retraction are commonest malignancy, but it can also be congenital. It can occur in chronic mastitis and sometimes other chronic forms of inflammation in the breast, like the antibiomas and tuberculosis. Axillary lymph nodes, today it's best to note them in terms of levels. And in the levels, remember, it is the posterior group, the central group, and the anterior group that form the level 1. The nodes behind are little higher central group nodes behind the pectoralis major, and they are level 2. And beyond the medial border of the pectoralis major, it becomes level 3. In breast carcinomas, it is so obvious, but still you'll find examiners asking, do you have a differential diagnosis? It's very rare to have these conditions, but please keep these in mind. Traumatic fat necrosis can mimic a breast lesion, but you'll have that history of trauma over there. Antibiomas, younger patients will have an anti-inflammatory lesion treated with antibiotics, and then it doesn't settle down, and then you get this chronic kind of appearance, hard, tender. Skin changes, pudy orange and all will come positive. Fibroadenosis sometimes can give you a tricky situation, especially when smaller lesions. Smaller lesions and the granular feel of fibroadenosis, that is ANDI, abnormalities of normal development and involution, they can give you some trouble. Phylloides tumor, always remember the size is much bigger than the duration. It will be a short story, but growing very quickly to a big size. And that gives you a clue that it may be there. And they're all freely mobile. They don't get any fixities. The fibroadenoma is the classical breast mouse, and a chronic disease like tuberculosis sometimes comes up in a differential diagnosis. So keep it in mind. Imaging, yes, the ultrasound in the small breast, in the dense tissue breast and other things, ultrasound helps. Mammograms are useful not only for the same side, opposite side, as well as the axilla, and also for helping you to localize tumors. MRI, I told you 3 indications. One is in the prosthesis breast, the pregnancy, and when you have bilateral disease being suspected, when you want to compare both sides. The role of PET scan is very, 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 very limited. In early breast carcinoma, you don't do it unless there's some indication of spread. You should always know what the role and indications of ultrasound in the abdomen is, CT chest, and bone scan is. When will you do each of these in your metastatic workup? That is a question that you'll be asked. Evaluation cytology versus histology. If you are FNAC, what is the needle size, how you do it, how many passes, what stains do you use, Giemsa or Papelikov or HNE. Grades of report, what are the AC grade 0 to the AC cytology grade 5, what are the different levels? They may ask as a theory question. If you do core needle biopsy, what is the needle used, how is it done, what is in situ carcinomas, and what is the breast cancer profile? Your receptor studies and your tumor gradings in terms of your euploidy, polyploidy, and the nature of the cells to tell you the malignancy potential. Is there a role for excision biopsy? Sometimes you may need to excise that tissue and send it to biopsy. This is again in centers where your backup facilities are not good. You are in a smaller place, you have only a pathologist with you, you don't have any recourse to other stainings and methods. You still have the place for excision biopsy, but that is slowly going out of vogue. In the discussions, you must know the difference between these 3 things: mass, lump and swelling. Lump is something that grows within a contained organ. Mass is also a word used for generally within cavities like abdomen and other things. And swelling is something that protrudes from the surface. For breast, the word is lump. You use lump. And lumps can be excised, but masses, there's no mastectomy. You can have to. And swellings can be excised in some form of ectomy. So the differentiation is all in the play of English. English has got a lot of different ways of expressing things, and that's why this confusions occur. Multifocal versus multicentricity versus multifocal. Some people keep on pulling people on this tethering versus dimpling versus puckering. Tethering is something visible, is something that is felt. It's a connection between two tissues. Dimpling is something that is visible, and puckering is something, dimpling getting worse when you do certain movements. Skin involvement mechanisms, how do you get pudgy orange, how do you get tethering, how do you get nipple staging, and your TNM classification. This is very important. You must know it, and you must know the clinical correlations. As I mentioned, tethering is something as how the tissue feels, whereas dimpling is a little visible change, and puckering is an exaggeration of that dimpling change that you see when you move the breast around. You must know early breast carcinoma, breast conservation therapy versus MRM. You must know a little bit of sentinel lymph node biopsies. You must know your axillary lymph node clearances. Now, if you have reached this stage and there's still time and they're asking you a question, it means they've gone right through. They're taking you through for your gold medal. You're doing well. Smile, relax, get that tension off the face. You know you've passed your exam. When you reach these levels of questions, then you can say, let me answer properly and see if I'll get it. So you should know about concepts of breast carcinoma. What is the Halstedian concept? What is the systemic Fisher's concept? And what are the conservative measures that are there? You must know a little bit of familial breast carcinomas and the chromosomes involved. What is oncotype? What is mammoprint? What are cell doubling times? The types of breast carcinoma, luminal A and B, the triple negative, the HER2-rich breast carcinomas. And you must know one chemotherapy regime properly, one set of hormonal therapies properly, and one set of radiation, how it is given, dosimetry and other things, coning, dosimetry in full detail. You don't know where your questions will go, but you need to know these things in your breast case. Again, if you're going for gold, they may ask you what's reversed axillary mapping. Reversed axillary mapping is you put a dye in the hand and you see where the dye is taken up by the lateral group of lymph nodes. And then you can dissect the axilla, retain those lateral lymph nodes, and remove the rest. They find that the incidence of lymphedema is little less. What is the role of oophorectomy? Somebody asked about oophorectomy, chemical, surgical. Today it's all gone out. We are not doing so many oophorectomies. Either radiation or chemical oophorectomies do their job. You must know a little bit of DCIS. You must know lots about prognostic factors, especially in histology, number of nodes, involvement of nodes, histological changes in the nodes that will tell you the prognosis for the patient. And if you have a BCS case, it's all about follow-up. How often will you call them for follow-up? What are the tests that you'll do at each follow-up? And how will you assess these patients? Some questions that are called up are early breast carcinoma and pregnancy. What will you do? What is a salvage mastectomy? Salvage mastectomy is a recurrence after BCS therapy and the tumors come back and you need to do surgery. That mastectomy is called a salvage mastectomy. What do you do in bilateral breast carcinomas? And what are the few oncoplastic procedures like thoracodorsal LD flap, or a tram flap, or a divep flap, or sometimes even an anterolateral cutaneous nerve flap, how you use those oncoplastic procedures and the timing of those procedures for these things. So with that, that is a brief thing only about early breast carcinoma. So you need to know all these things and all these possibilities of questioning coming up during these cases. So there's plenty of reading to do. Please go ahead and do it. Thank you and best wishes. Dr. Patta sir, I think I finished.
Yeah, it's a wonderful session, sir. And I think Irshad is presented well, and he
Yes,
deserves
he
a,
passes. He goes straight through. There's no doubt on it.
Thank you, sir. Thank you, sir.
Hey, but Irshad, don't get hot and give up and do well.
Yeah, sure, sir. Thank you, sir. Thank you so
Good
much.
doctor also, good surgeon.
Sure, sir. Thank you,
All
sir.
the best. Yeah.
Thank you, sir. Thanks for sparing time and teaching
Yeah.
the students.
Thank you, sir.
See you again sometime. Thank you so much.